My name is Max Nevis. I am a medical device sales rep. I work for a company called MDUSD. We're owned by Johnson and Johnson. Johnson Johnson, huge company. I'm sure everyone's heard of them. But MDUSD is just a subsect of that. But in the medical device world, it's a pretty big company. It has a pretty large kind of market share of just medical devices in general. My title is I'm a orthopedic trauma medical device sales consultant. So that pretty much means I handle broken bones. Orthopedics has to do with bone injuries, and trauma is obviously broken bones. I focus on trauma and extremities. So anything your legs, your hands, your arms is kind of the things that we sell. I do, and here are a couple pictures. On the left is a humerus, a proximal humerus, and that's one of our plates, and those are the screws that go in. In the middle is a distal femur. So those plates, they fix, broken femurs like that. And then on the right is a intramedullary nail. So it's a nail that goes inside of the canal of the bone. So we sell these products to the hospitals. And what that pretty much, entails is, I have relationships with the surgeons, the physicians at my hospitals that I work at. And I have relationships with the nursing staff, all the people in the OR, because, pretty much I'm going into the OR every day. And I'm working with the doctors to make sure that all of our products are there for certain surgeries. And then I'm also in the OR while they're performing the surgery to provide any sort of service if the doctor has questions, or if they, the scrub tech, who's the person that hands the surgeon all the instruments. I help set up their table with them so that they have everything out ready to go, so that the surgeon isn't they're not in the middle of a surgery with someone cut open and they're trying to fix bones and they're like, hey, I need this. So that way they're not just sitting there waiting. I'm there to point out what's in our sets and what's in our trays that the surgeon can use to help fix that surgery. So some of the stuff we see, it kind of varies, right? So these are all Xrays that surgeons have sent to me and said, hey, Max, like I'm doing this surgery. I want to use this specific plate, or these types of screws, or something like that. And I make sure that the hospital has that stuff and is ready to go. For the most part, like I said, MDUSD is a pretty big company. So most of the hospitals, especially in my area, they keep most of the stuff there. In-house is what we call it. So it's just in-house there. And because of the process, right, everything needs to be sterilized, and it's wrapped up and it's put in a sterilizer, and it's brought to a certain temperature to make sure all sorts of bacteria or pathogens or anything like that are all killed. And then it's brought into the OR and it's safely opened, and someone that's scrubbed in and sterile with sterile gloves and a gown and hat, mask and everything, they take it, put it on a sterile field, and keep everything sterile. So most of our stuff lives there. So it's pretty much sterile and ready to go for anytime the doctor may need it. So if we look at some of these X-rays, right, up in the top left, I mean, the fractures could be something super basic like this, where it's just a broken thumb. If you look at the thumb, the bone, you can see that there's a little bit of a break there. And for something like this, the surgeon could just use like a small little plate, or he could just actually put wires in there to hold it and then cast it, and then the bone kind of naturally heals on its own and starts to fix itself, right? In the middle is a little more serious. This is a femur, a proximal femur, so pretty much your hip joint, right? And you can obviously see that that's not what your hip is supposed to look like. There's a big chunk off to the side, and it's all compressed and out of alignment. So for something like this, you want to do something more of like a nail, right? Where you put your nail down into the middle of that femur, and another piece goes up into the head like this. It creates a little cross, goes up into that head like the picture I showed on the other slide. And the bone starts to heal indirectly, and it starts forming calluses and healing like that. Something on the right like that, it's a both bone forearm, so both of the bones in that forearm are clearly broken. Something like that is just two different plates get put on there, so they open it up and put a couple plates on there. And then with that, this is on the bottom left is a knee, distal femur, clearly broken. This was just actually I did this case over the weekend, and we put a big old plate on there and put a bunch of screws in there to hold everything and allow that's direct bone healing, because that plate is providing a strong surface so that the bones can stick together, and once the bones are together, they'll start to heal. And so for me, when I get these X-rays, I text with the surgeon or the nurses or the surgeon's schedulers, and I say, okay, yeah, we have this product that can be used to heal or be used to treat this, and I want to make sure that stuff's at the hospital. I want to make sure it's complete. All the screws are there. There's nothing worse than opening up a tray and there's missing screws, and by the doctor starts putting in screws, then all of a sudden he's like, I need another 14 millimeter screw. And you're like, I don't have one, and, these surgeons are, I like to think that I have good relationships with a lot of them, but they probably could care less about me. They're like, as long as my stuff's there and it's good to go, like, I'm happy. And then if you mess up, it could be, you lose the business just like that, right? So here's a couple pictures of just some basic stuff. The big picture in the middle, the bottom, those are distal femur plates like we put on the patient from this weekend. So a distal femur, you can see there's all sorts of different screw holes in there. You just kind of put that plate on the lateral outside portion of the bone, and you start to let it grow back. Up in the top right, that's called our small fragment. So that's just really basic tray. It has all the drill bits. It has the screwdrivers. It has the depth gauge and some clamps and K-wires and things like that. And that's for the doctor would use this tray for like that both bone forearm fracture that was on the last slide. Underneath that top level where there's all those drill bits and stuff, you lift that up and there's a bunch of plates and a bunch of screws. And the doctor will make his incision on the forearm. He'll use those clamps to put the bones back together or hold them in the right spot, pick his plate, and then start putting screws in. And then those plates are pretty thick and they're stainless steel metal, and they're they'll hold that bone pretty well. And then up in the top left, it's kind of a back setting of what if we're going to put a nail in, if we're going to put in a nail into a hip like that picture in the middle. Those are kind of the instruments. You can see there's some drills, and this kind of bigger dark thing is our aiming arm. So you may think that, putting in a nail is going to be a whole bunch of a big incision, but it's really just a small cut about this big, and they do everything percutaneously through the skin, and they kind of feel where they want to put it. And the whole time they have X-rays, so they're looking, they're double checking where they like it, if they like their placement, and then the nail just attaches right onto there, and they drill it, open a hole, and they just slide the nail in. And for me, cases like that where it's a nail is where I'll get maybe some more questions from a doctor where they're like, is that deep enough? Is that, does it look all right? Is that the right alignment? I mean, for the most part, doctors know what they're doing. They've been to school for a long time, and they've been doing it for a long time. And sometimes it's just me in there counting and keeping track of the screws and the plates that they use, because they don't need my opinion. I'm there to make sure the trays are there, and then to make the scrub tech's life easier. And then there's times where I'm on call, and the surgeon that's on call is, let's say he's a hand doctor, so his day-to-day is fixing bones in the hand, but he's on call and he has to do a nail, and he does a nail like he does. Sorry, my dog. I don't know if you hear my dog, but my dog's in the back.
You're all good.
But you get a hand doctor that's on call, and he has to fix, a femur, and he does, a handful of these a year. Maybe he'll lean on me a little bit more to kind of provide some insight on my opinions on what, what may be the proper techniques or the proper steps and things like that.
And if you have a fracture, like let's say like a comminuted fracture where there's a lot of different pieces, do you have any products that kind of help for that?
Yeah. So when it comes to like comminuted pieces like that, where the bone is just kind of busted up, there's a couple different things you can do. We have things called variable angle screws, and if you look in these plates, these holes that are kind of they're not just like a straight circle, they're kind of almost like a T, like on the ends, those holes. You can when you put a screw in, you can actually change the angle of where it's going to go, and that allows you to grab multiple pieces of the bone, and then it'll lock itself into that plate, and so that those bone pieces will kind of stay there. And then there's another technique where things are just really comminuted. You'll kind of see it in like more of like a gunshot or something like that, where the bone is just, I mean, the pieces are so small, you're not going to be able to grab them with a screw or something like that. And you do what's called bridge plating. So if you got a gunshot wound right here and it's all comminuted, they'll put a plate on that covers the whole thing, and then they'll just put screws in on the sides and not through where it's all comminuted. And the bones will eventually, they'll start to heal themselves, or that's what you want. As long as ideally you want the bones to be touching each other, but when it's so comminuted like that, you kind of hope that they're close enough to start kind of rebuilding. And then you can also put grafts in there. We have something called Vivigen, where it's osteogenic, conductive, and it kind of provides scaffolding. So like if you think of it like the scaffolding of a building, you can put it in the bone, and it provides like a a bridge for the bone to grow across. And then it also has properties that allow that induce the bone growth. It has bone cells mixed into it, and so it allows the bones to start growing faster. So there's a few different things. I think it's about 10% of fractures don't heal or end up healing in a malunion or a non-union. A malunion is just when if your bone is supposed to be straight, if it heals like this and it's all curved now, or a non-union is just where it doesn't heal at all. And if it's supposed to be like this, it starts to kind of grow its separate way. And those are a lot of the time that's going to need some sort of revision surgery where they'll have to saw the bone. If it's a malunion, they have to like saw it down and re-break it, re-put it back together, put some of that graft in there, and that way it allows it to kind of heal. But yeah, I mean, when you think of bone healing, you want your bones to be touching to provide the best growth, and you want the bones to be in the right spot, because if a malunion may happen where if they heal like this, then it'll just start to get worse and worse. But if they're perfect, then there's a good chance that they're going to heal, perfect. And that's why for certain fractures you use direct healing, which is where you put a plate on there, and it provides that, it keeps those bones together. Or indirect healing, where it's like a femur fracture, and you put a nail down there, because the goal of it is to get the patient walking as soon as possible. Them walking is going to compress your femur and push it down, and then that will kind of allow it to start forming that bone growth. And then this next slide, it's kind of bloody. There's this is kind of my view in the OR. So you can kind of see, I put a couple different pictures. The top left is a motorcycle accident. The guy's leg was, pretty shredded up there. Then you can kind of see the doctor's putting a plate on there. The bottom left is called an Xfix. So the guy broke his proximal tibia, tibial plateau fracture. And you can kind of see it's pretty swollen. And there's a thing called compartment syndrome. And if you get compartment syndrome, it can lead to necrosis and your tissues dying. So they put an Xfix on there so that you can distract it and keep your femur and your knee separate. So that way it's not all compressed, and you don't displace your fracture anymore. And that way you can kind of pull it out to length. And that way in a week, when they go back in and fix it, then it's a lot easier to fix. In the middle, they're doing a proximal humerus. You could see the scrub tech. She's kind of picking out the screws. And then the surgeon, he's got his hand on the plate inside of the person's humerus. And he's getting ready to put a screw in. The top right, that's a broken femur. So that's a leg. You can clearly see that broken bone. And that, he decided to really just open that thing up. We have products that allow you to not open it up like that, but some surgeons don't like to deal with it. They maybe think it may be a little bit more tedious because it's an aiming arm that sticks off the side, but it allows you to make incisions that are a lot smaller. Also for that one, he was having trouble really reducing it without opening it up. So if he opens it up like that, he's able to reduce it, find a spot, clamp it down, and then we'll put our plate on. And then the bottom right is just kind of like my view, right? You could kind of see some of my trays. That's a clavicle tray and the small frag tray like I showed. And it kind of goes through, that small frag tray can be used for so many different plates that we have. It could be used for, just putting screws across, things like that. So it's always good to have that open. And then here's some X-rays that we've just some basic X-rays that we kind of have. That these are cases that I was in, right? That top left one is kind of like what I was telling you with a gunshot wound. So that top left is a gunshot in a patient's radius. And so the doctor wasn't going to try and put all these screws through there to kind of hold it. So in the picture where there's the screws and the plate, you can kind of see there's those cross screws. And those are just to hold the bigger pieces together. But then you can still see on the side that there's some bone fragments that are kind of out there. But what he did was he bridge plated it. So you could see he put screws distally and he put screws proximally. And then he kind of allowed that to kind of hold itself, and that bone will start to heal. In the middle, that's a pelvis. We don't see too many pelvis fractures, just because a lot of the times a doctor can do a pelvic fracture with just some screws and they don't need us. But something like this, where it's a pubic symphysis that it splits open. So he put a pubic symphysis plate on top, and then he put a staple in there also to kind of hold it. The top right is a clavicle. So they broke their clavicle, and they put a staple going anterior or superior to inferior, and then they put the plate anterior. So they put the plate in the front. They put a staple on top to hold it, as well as also those two little black dots. Those are screws to hold it up top, and then they put a plate in the front and put screws in. Just a basic distal radius on the bottom left, just a small little plate. The screws are just 2.4 millimeters in diameter, so they're pretty small, and they just kind of hold up that bone. The one in the bottom was a pretty cool case. The patient had a pretty broken femur. The proximal portion was broken and the distal portion was broken. So what they did was they put in a nail, and that's what you can kind of see like in the middle of the femur. So they put in this nail that goes they open it up at the knee and it goes up through the femur. And then they put this, it's called a dynamic hip screw, and they put that up into the head, as well as a anti-rotational screw. And then they put screws through the plate that sits on the outside. So that was a pretty cool case to see. And then on the far right is just a tibial nail. We ended up actually removing this one. This was a removal, but it's our nail that's in there. And you can see there's screws going down by the ankle joint, and then there's screws that aren't in the nail itself, but they're even more distal. And that's just because the ankle joint was kind of split. So your ankle joint sits up here, and it was just kind of split like this. So they put a couple screws across to hold it, put the nail down the tibia. This is pretty much like what like Tiger Woods may have gotten in his because he had a pretty broken tibia. So they did something like this. And then going back to like maybe that external fixator, that thing that was sticking out of the patient's leg down here on the bottom. Alex Smith got something like that when he broke his leg, and he had a big old ring. It's called a max frame, and he had that on there, and that really helped him heal his process. And then, I mean, just a couple more pictures. There's, this is one of our nails here on the left. It kind of shows you the different screw options that'll go in a femur. And then we have things like really minor, like in the middle, there's just these really small hand plates that they're only 1.3 millimeters thick. They're really small, but they have a lot of uses, as you can see. And then just something like an ankle plate over here. So, I mean, my job it's very cool and it's very interesting. My day-to-day is every day is different. Every day is, as a trauma rep, I don't really know what's going to happen the next day. You know, there's only so much that a doctor could say, hey, I'm doing this case tomorrow, but there could be times where, hey, an emergency case came in, we need this stuff here, we're going to do this case. So every day is different, but for me it kind of consists of, if I have surgeries planned, I'll do those surgeries. I'll be there. If not, if I need to take a tray somewhere that maybe doesn't have one, if I need to bring a tray in for surgery the next day, I'll do that. I will, I'll do, I'll have to return trays. I get a lot of stuff shipped to me. So like if a hospital uses something and it gets mailed to me, so I got to go to the hospitals and I got to restock them and get them ready to be used again. And then sales calls, right? I mean, it is a sales job. It's although it's in healthcare, and a lot of the sales comes with more just kind of relationship building and relationship maintaining, compared to like going into a doctor's office that you don't work with and being like, hey, I'm Max, I'm the Synthes rep, look at this, right? A lot of the time they're busy, they don't want to do that. They're like, I use this already, it's fine, I haven't had any issues. So a lot of my sales pitches come when I'm in the OR, when I'm talking to a doctor before we go into the surgery, and I'm like, hey, we have this new product. I don't know if you've seen it. This is what it does. This is what it can help. This is kind of the goal of it. And I can come by and we can talk about it some more. Then from there, you know, it'll kind of snowball into more of a sales pitch from there. But yeah, I mean, for me to get here, it was just kind of, I went to Chico State and I did exercise physiology. So I was kind of in that health, anatomy and physiology. I was kind of in that health degree pathway, and I was fascinated by it. A lot of my kids in my class were, either going to go to physical therapy school or PA school or chiropractic school or become nurses, things like that. Become even like PE teachers and, just things like that. And I was thinking, maybe graduate school, but when I graduated, I was like, no, I'm done with school. I don't want to go to school. I want to work and I want to, do something cool. And, after talking with people, I kind of found this job, and I was able to luckily, every time I tell someone how I got into this job, they're like, wait, did you know someone? How did you get into it? But it was just lucky. I was on LinkedIn and I was applying to jobs, and I interviewed and they liked me, and, we went from there, and now I've been with them for about 2 years.
Awesome. Yeah. I was actually wondering, so I bet your company's always making new products to sell. So do you always have to read up on those products and become more knowledgeable about them and what they do?
Yeah. So, I mean, we are always making new products. I mean, it takes a while to make a new product. I mean, there's so many regulations it has to go through to fully come out, but we do make a lot of new products. And when we do, we as sales reps, we go through a training, like an online training, where it shows us all this stuff. We have to take a little quiz on it. And then there's also we have like Zoom calls, where the product developers, they'll talk about it. And most of the products that get developed, they have surgeons that are kind of lend their opinions on it as well, like a surgeon consultant, and they'll kind of say what if it's an existing product and we're updating it, they'll say what the issue is with the existing product and how we could fix it, and then the product development will fix that. If it's a totally new product, then it's just something that the doctors and them worked on. Like we have a new thing now, it's called a graft cage, and it's used with patients that have like tumors or things like that in their femur or their tibia. And it's a personalized 3D printed cage. And so if a person has a tumor on their tibia, the doctor will go in and he'll just cut out that section of bone, and then he'll put in this graft cage that's 3D printed to fit that patient through CT scans and things like that they send to the company. And then they put a nail down the cage, and then they put some of that like bone graft, that Vivigen or something like that, around it to really help it heal. And that's like a totally new thing. I mean, I have never even seen one done personally. It came out last year, the end of last year. And I think in California, I think there's only been like 5 of them done, and one of them was at Stanford. The rest were elsewhere. But, we are always learning. And I'm also doing cross-selling for the sports medicine division. So that's like more soft tissue damages. So like torn ACLs and rotator cuffs and things like that. And I don't, this is my first like week training on it, but I mean, that's a lot more like small little sutures that they'll use to tie your ligaments back together, and so that they can start to heal better that way. Instead of a big old plate. And so it's, I am always learning, even in the ORs. My first full year, I was at a lot of like teaching hospitals. So I was at Stanford, and I was at Santa Clara Valley Medical Center. And those are teaching hospitals where they have residents and fellows on rotation. They're doing their rotations, and so the main surgeons there, the attending surgeons, they have maybe a couple residents and a medical student, and they're teaching them, as they're going through it. And that also allows me to learn. And it's like I'm sitting there and I'm kind of listening to them and listening to their tips and their tricks. But then there's even times like even two years in now where if I see a doctor do something that I haven't seen, I may say, "Hey doc, what's your reasoning behind putting in screws that way?" Or how do you normally, reduce your fractures like that? That's a cool technique, and I've never seen that, right? So a lot of the times, if you have a good relationship with a doctor, they like that you ask questions. It shows them that you want to learn, and you're interested, and you're not just sitting there on your phone. Like, because a lot of the times, I mean, surgeries, they could take hours, right? I mean, there's surgeries that the longest surgery that I've done was 12 hours long, and it was brutal. And it was a Sunday from like 8 p.m. or 8 a.m. to 8 p.m. And I was just like, oh my God. Like, and most of the time they don't need me there for those hours, but I have to be there, because if the surgeon is going to make his incision, he's going to work on reducing that fracture perfectly. And that's going to take him, 5 hours to do. By the 6th hour, he doesn't need, or that's when I'll come in and he'll put my plates on and stuff. But I need to be there, because a lot of the times, if the surgeon, he or she will look at me and say, "Hey, I need this." And I'll be like, "Okay, I know where that is. Let me go get that for you." So, there's times where it's just brutal. But then there's times where, like I said, it's the surgeon doesn't need me there really, but I want to be there to provide service. I want to be there to help the scrub tech. Because a lot of the time the scrub tech, I mean, they don't, it's not their job to know how to fix a bone or what drills go with what screws. So if I'm like, okay, let's get out this stuff, have that all out. That way it makes it a little bit easier on the surgeon and the scrub tech overall.
Yeah, definitely. I really like how you're always learning. You're always finding new experiences. So that's really cool. It's a really cool aspect of the job, I think.
Oh yeah, it is a very cool aspect, and that's something that I've definitely loved about it. And just like, I mean, every day when you go in, you don't know what your cases are going to look like. I mean, even if it sounds like it's a basic case, like there could be something that goes haywire and something happens, and you have to totally have a plan A, B, and C and D, right? And so you need to be learning and thinking about these types of plans. Like the case last night that got had me delayed. It was supposed to be just a basic removal case where they were going to take out something, and it ended up taking 3 hours for them to take something out. And it's just because your bones start growing over all of this stuff, and it makes it really hard to get it out. And then screws, if you're cranking on them, maybe they'll break, and then it's like a whole issue. And it's not the, like when I first started, I was like, oh, removal, that sounds easy. I'll go, yeah, I'll go do a removal. And I, like the first one that went bad, I was like, whoa, this is terrible. Like, because the surgeon's looking at you, they're like, don't you have something that can get this out? And I'm like, I've given you what was designed for it. We just, there's a lot of bone growth, and there's all sorts of factors. So there's always things that really play a funky part in the day. And then, you're also on call, which is tough as a trauma rep. You're on call. There's all sorts of different divisions of this industry. There's joints, there's sports. Joints, they do the total hip replacements, total knee replacements. But when you're on call for a joint as a joint rep, most of the time, a joint case can go on Monday, right? It's not an emergency. Same with like a torn ACL. It's not, we don't need to rush in on a Saturday and do that. As a trauma rep, I've gotten called at 3:30 in the morning, and I've got to get up and go to the hospital and like have everything ready. Like one of the pictures I had, that really open leg where it's just really kind of torn up, that was at 4 a.m, and it was a drunk driver, and his leg was all busted up, and they called and they're like, hey, when it's open like that, they're like, we need to do this right now. So it doesn't really matter what time it is. If it's closed, if it's just a broken wrist, that can go a different time. But as a trauma rep, being on call, you're like, okay, like I was on call last weekend, right? And so I'm sitting there, and it was Friday night, and I was like, okay, maybe I'll get off scotch-free. I won't have to go in. And then at like 8 p.m., I got a call, and I had to go in. So there's times like that where it gets tough. It's a lot of work. But I mean, overall, it's very rewarding, right? I feel like I'm helping people. Even if it's indirectly, I don't ever talk to the patient. I don't ever see how the patient's doing afterwards, or maybe sometimes, but not often. Unless I talk to the doctor, I'm like, if it was a really weird case, and I'm like, hey, how's that patient doing? That but I never see them again. But I still feel as if I'm kind of providing a service to help them get back to normal. I'm helping the surgeons. It's really rewarding when there's a tough case, and or a surgeon is trying something out for the first time, and he doesn't know all the kinds of tricks with it and stuff. And it's really nice. It's really rewarding when it goes well, and the surgeon's like, hey, thank you for being here. I really appreciate it. Like, it's like, who am I to help this surgeon that's been, going to school for so long? But there's times where it is really rewarding. And I mean, it's a lucrative industry. I think it's like the high end people are, in the top 3% of salaries in the US or something like that. So there's money to be made there. And that's what, sometimes even if I get called in at 3 a.m. and it's a really basic case that they probably don't need me there for, if I think about that, then it makes it a little bit better too. But it is really rewarding. And that was one of the things I wasn't like really expecting it to be. Like when I first started, because when you first start, before you start covering cases on your own, surgeries, you're running trays around all the different hospitals, or you're just kind of a fly on the wall in the back, and my senior rep was doing everything. But now where I'm at the point where, I can pretty much cover all of the surgeries that we offer, it's a lot more rewarding, and it's a lot more, it's just, yeah, overall, it's just a lot more rewarding now that I can do things on my own.
Yeah, and then I want to respect your time, so I only have a couple more questions.
Yeah, ask away.
Um, yeah, so it seems like you kind of are working two jobs. Like one, you're a sales rep, and the other, you're kind of in that medical industry with healthcare. I'm just wondering how those like two interests came to be. Did one come before the other? I'm just really interested in that
Yeah.
intersection.
Yeah. So for me, it started with being in exercise physiology in college, and just like learning the human body and being like, I mean, this is interesting. Like, this is really cool. Um, I like this. I had an anatomy class where, we worked with cadavers, and just, learning the human body I thought was very interesting. But I also, there was no chance that I was going to be able to ever go to medical school. And there was no chance that I wanted to go to school for that long. And then the sales aspect came after kind of talking with people, because to be honest, my first kind of idea, post graduation, I was like, okay, maybe I'll go to chiropractic school. Like, I get to work with the human body, and I liked going to a chiropractor from my football days in high school and stuff. So I was like, oh, maybe this would be cool. And then I was talking with people that were in the industry, in the medical device industry, and kind of listening to them, listening to, their experiences in it. Being in the OR always sounded cool. And then kind of like I said, the financial benefits of it are nice as well when it comes to the sales aspect of it. And then also working for Johnson and Johnson, like, just my overall benefits are very nice, like health benefits, and um, you know 401k benefits and things like that are just overall very nice. So um, I think it was just kind of that first kind of interest in the human body, and then learning and kind of seeing what else was out there, that kind of brought me to this, which is why I think it's cool that I'm able to kind of talk with you and the rest of the class, and kind of show them that there are other kind of ways to go in healthcare that are very interesting and very rewarding and very fulfilling.
Yeah, totally. This is just one last question. I don't know if it's going to be a fun one, but what's like the most memorable surgery you've ever been a part of?
So there's been, there's a couple. So probably honestly, that picture that I showed that was like 4 a.m. Of the motorcycle accident, the guy's leg. That was probably one of them, because that was one of the first kind of really big cases that I did on my own without my senior rep. That was like really big like that, where it's an emergency. They're like an extreme emergency where the doctor's like, I don't know if we're going to be able to save this person's leg. Like, we may end up amputating it. So I get in there, and, it's just like, there's vascular surgeons that are connecting veins and arteries from the guy's femur to his foot so that they could try to save the foot. And there's the orthopedic surgeons that are trying to put that plate on there. And it was just, there's so many different moving parts going. And in the other room, there was, because what it was there was a drunk driver in his car, and he hit a guy on a motorcycle. So the drunk driver that was in the car, he was in the other room. He was getting another surgery, and so I was kind of running back and forth. And so that was a crazy one. But then there's also been really cool ones where I see a sort of technology that we have, or kind of a way that a surgeon will do something. So there was a case where it was a gunshot in a person's arm, and it was a shotgun. So I mean, it was just blown up. It wasn't just like one bullet. It was just totally blown up. So what they ended up doing was, we have a system that collects bone marrow from someone's femur with this. It's a big reaming system. So you make an incision up on the hip, and you drill into the femur, and then the drill also kind of sucks up that bone marrow. So it drills in there and sucks it all up, because that, if it's from this patient, the same patient, that's going to help them heal the most. And so we did that. We collected a bunch of bone marrow. And then what the surgeon did was, on your fibula, on your leg, that bone, it doesn't have any weight bearing. It's you know, it's not that useful, I guess. And so what they did was they cut out a section of the patient's fibula, and then they put it into their arm where the bone is supposed to be. Took all that graft that we grabbed, put it all in there. They had a vascular surgeon come in and connect some of the veins and arteries that were still on that piece of fibula to like the arteries and the veins in the person's arm, and then put a big plate to kind of cover the whole thing. So like seeing something like that where you're like, well, that is cool that, like, they're able to do that, is pretty memorable as well. And then there's the memories of just like having it be a terrible case where everything goes wrong, where you're like, oh my gosh, like there's a hole in the wrapping of one of our trays, so it takes him an hour to get it re-sterilized, and the doctor wants it right now, and he's looking at me and he's like, why is this not ready? I start getting all hot and sweaty, and I'm like, oh my God, like, you start getting stressed out. Everyone's like, why, what's going on? And you have to try and think on your feet. And so there's cases like that are just, those aren't the fun memories. As bad as that one injury was with the guy's leg, that's kind of a cool memory, case where I was really able to help the whole OR team in general, where the bad memories of cases are when the cases go bad, even if it's just a basic case and something goes wrong. So there's a lot of memories that come with the job, but most of them are good. And my very first day ever, I always tell this, it was a tib-fib fracture. So the guy's fibula and tibia were broken, and they were just going to put a nail down the tibia, because a lot of the time, like I said, the fibula is not weight bearing. So as long as it's straight, it'll just kind of heal itself. So they put a nail down there. But I remember my very first day ever on the job, I went to Stanford and I was shadowing with one of my senior reps. And the surgeon comes in and the patient's on the table, and the surgeon lifts up the patient's leg because they're going to clean it and make it sterile. He lifts up the patient's leg, and this is the middle of his leg, and his whole foot just flops down, or his whole like middle of his tibia and down just flops down. And he's like, oh man, we got a super floppy one today. And I was just like, oh my gosh, what did I get myself into? Like, what is this? Like, this is insane. But yeah, I always thought it was a pretty funny memory to have as my first day, having a surgeon say that, because it's just such a random thing for a surgeon to say, but it makes sense.
Yeah, definitely. I've been really enjoying hearing how like you've kind of become the doctor without having to do like 10 plus years of extra schooling. It is really cool.
Some of my friends were like, Max, I'm glad that you're here. Like, that way, if any of us break something, you'll be able to fix it. And I'm like,
exactly.
the part of me thinks, after doing this for so long and seeing so many surgeries, part of me thinks that on like a basic surgery, I think I could do it. I would never do that. And it's also I would never be able to do the dissection aspect of it. I wouldn't be able to know where the veins and the arteries are and the nerves that I've got to stay away from, and what muscles to kind of split in order to allow them to heal properly. That would be the biggest thing. But if there's just two bones right there and they just give me a drill and a screwdriver and some
You can do
screws, I got you.
it. Awesome. Well, thank you so much for meeting with me today. I know I learned a lot. I really hope the students who watch this also learned a lot. And yeah, I'm just really excited